these, but how do you...
Is Maija Hollmén. She's an Akademi fellow, and she talks now about Clever, as Marco already introduced. Please, Maija.
Thank you very much, Sirpa, for the kind introduction, and thank you for having me here to talk about my favorite subject, which is Clever One. Just a bit of my background. So I did a master in health biosciences in drug development. And after that, I did a PhD in Klaus Elenius' lab investigating epidermal growth factor receptor targeting in breast cancer, where we developed antibodies. So my presence with antibodies and research has very long been investigating how we can improve drug development in that way. And then I went to do a postdoctoral research period in ETH Zurich, where I actually did studies in macrophage cancer cell crosstalk to understand how these immune cells talk to cancer cells and how they modify the tumor microenvironment to support the tumor growth. But today I will talk about the next generation immunotherapies, which I believe are targeting macrophages as one approach to improve therapy responses. This is a schematic representing where we are currently in drug development and drug clinical treatment. As you can see here, the early days, you were utilizing chemotherapy to treat cancer, and this is the LILA. This is representing an overall survival Kaplan-Meier curve, where it shows that applying chemotherapy to patients increased their survival a bit, but in any case, the people died to their disease. Thereafter came genomically targeted therapies such as Herceptin, which targets the oncogene ERP2, and it could increase survival by a few months, but eventually all of these patients receiving this therapy also died. Then came immune checkpoint therapies, which of course Tasuku Honjo and Allison got Nobel Prize for. And they could show that applying these immunological drugs to patients, it could actually prolong the survival of about 20% of cancer patients, which was like a really good approach because there wasn't anything that would actually have a permanent effect on cancer patient survival. However, they are not perfect either, and we would want to increase the survival of patients up to almost this, or even better, but again to this red line here. So how could we do it? One approach is, of course, to combine different treatments to these immune checkpoint inhibitors. The thing is that what we know currently is that the immune checkpoint inhibitors work the best for tumors that have high infiltration of immune cells, especially T cells. So they are shown here, and they are described as to be inflamed tumor microenvironment. Then you might have an excluded tumor where you have the immune cells around the tumor, but they cannot get into the tumor to kill the cancer cells. And then you might have a desert where you don't see any immune cells at all, and it's very immunologically very cold. So this is all great. You can have checkpoint blockage therapy working in these, but how do you treat these patients? And there are several of these in the cancer patients. But this gets even more complicated. It's not so simple. So within these different immune types, you might also have a different distribution of activated effectors that Rita demonstrated, these effector T cells, but you can have also exhausted effector T cells. So even though they are there in the tissue, they are not working because they are exhausted. So there is chronic antigen exposure and they cannot function properly. What is also important to notice is that the composition of different immune cell types in the cancer can have a meaningful in the immunotherapy responses. So you can have a prevalence of effectors, which is again supports the likelihood of response to immune checkpoint blockage. You might have an equilibrium, but then you can have a prevalence of suppressor cells like myeloid-derived suppressor cells or immunosuppressive macrophages that provide resistance to these current immune checkpoint therapies. as I mentioned about the combination trials, there are many. So you can see here, this was already in 2018, where you can see that over 1,000 trials are investigating anti-PD-1 or PD-L1 agents in combination with different treatments. The most combined treatments are with anti-CTLA-4, chemotherapies, radiotherapies, and so forth. These have provided much more responses that represent more of the red line that I showed you in the Kaplan-Meier schematic curve. But I have to say that most of them don't have any scientific relation on whether it would work or not. So it's not scientifically based. People just want to try everything they can to treat cancer. So what I think nowadays is that because the T-cell approach was so working and people have investigated what are the resistant mechanisms for immune checkpoint blockage, they have tried to identify other immune checkpoints on T-cells that could be possibly combined with the other checkpoints to make a better response. But I think this is not really the case to go. And to me, it sounds a bit like the mass suicide of the lemming. So there has to be some other options that we could utilize. So one needs to think better, I think. And how we have now gone to investigate and provide more beneficial responses to patients. I think these two images of a macrophage staining in colorectal carcinoma and pancreatic ductal adenocarcinoma proves my point. Macrophages, these tumor-associated macrophages, can consist of half of the tumor mass for a certain tumor. As you can see here, they are very abundantly present. Here you can see just a small piece of tumor and this massive amount of macrophages that are holding this tumor together, providing support, which you can see in this schematic here. So these macrophages are very plastic cells. They can promote metastases, promote EMT, promote vascularization to tumors, and provide growth factors to cancer cells and suppress immune responses against the cancer. This may be a bit provocative, this slide, I know, for a T-cell centric view, but I think how innate immunity and adaptive immunity works is that the innate immune cells, antigen presenting cells, tell T cells how to differentiate, tell T cells how to work in a way, so they guide the T cells in their differentiation. And what we are interested in is that we could, now that Laura mentioned this polarization, we want to do it the vice versa. So how can we convert these pro-tumor macrophages that express high IL-10, TGF-beta, and low antigen-presenting molecules? How are we able to convert these to anti-tumor macrophages that then have high IL-12, TNF-alpha, and present antigens and activate T cells and Th1 responses in the proper way? So we have been concentrating on Clever-1, and the name comes from Heikki Irjala, I think was the originating person who created the name. So it comes from common lymphatic endothelial and vascular endothelial receptor 1. And it's also known as stabilin-1 and FIL-1 because it was discovered by 3 different labs at the same time. So they weren't aware that they were investigating the same molecule. And these 2 other groups were investigating it in macrophage populations, whereas Sirpa was investigating it in the endothelial cells and how it regulates lymphocyte and leukocyte trafficking within tissues. When I came back from my postdoctoral studies from Switzerland, I was really interested in macrophages and how to convert them, and I started investigating Clever-1 on the macrophages within the tumor setting. And as we know now, macrophages that express Clever-1 are very tolerogenic. They regulate the resolution of inflammation and cause immunosuppression. And they also regulate tissue homeostasis by scavenging bacteria, apoptotic cells, and endogenous substances. So the idea was that how can we utilize blockage of Clever-1 to induce T-cell responses in tumors? And it wasn't clear previously when Sirpa had done all these cancer studies that what is the cell type that is actually regulating the effect that we see on Clever-1 and its activity on tumor cells or the tumor microenvironment. And this is why we wanted to do this proof of concept research article by utilizing Clever full knockout mice and then these mice that were where Clever was specifically deleted from macrophage subsets. And for this, we utilized this lysozyme 2 Cree mice and Clever floxed mice. And we implanted tumors, Lewis lung carcinoma and EO771, which is a triple negative breast cancer cell line. And notice that if we implant these tumors into these mice that were lacking Clever only in the macrophage subset, they couldn't grow tumors at all. We went further on to investigate why this was and what was happening in the tumor, and we noticed that in this macrophage-specific deletion of Clever-1, we see a high infiltration of CD3 positive T cells into the tumor. So we could really activate the immune responses. Here, why the Clever full knockout didn't behave the same way can be the reason that Sirpa was investigating that it also controls leukocyte and lymphocyte trafficking. And when you have a full Clever knockout mouse, it might, of course, impair the trafficking to the tumor itself. But when we tried also antibody treatment in these tumors, it was more representative of this macrophage-specific deletion. And we further did with flow cytometry analysis that these infiltrating T cells were actually CD8 T effector C cells. So a long story short, all of this information has gone to the development of a humanized antibody against Clever-1. So this antibody originates from the initial findings of Sirpa, which then was humanized this antibody and is now called bexmarilimab. It's an IgG4 molecule, which has undergone 2 mutations to prevent the Fab-arm exchange, which is typical for IgG4 molecules, but also this mutation here that aborts all the effector functions that it may have. And this is because Clever is also expressed on lymphatic endothelial cells and sinusoidal endothelial cells, so we don't want any effector functions to kill those cells. And this development we have done together with Faron and under this contract research agreements where we investigate the activities of bexmarilimab. And activity we noticed, so the mode of action of this antibody was published just this year. And to keep it very simple, what we noticed was that if normally these M2 macrophages, so these suppressive macrophages, scavenge apoptotic cells and take them very rapidly into phagolysosomes and to the trash. So it needs a very rapid acidification of these vesicles, and they are hidden from the tumor microenvironment not to be presented to the T cells. When we incubate these cells with bexmarilimab, we can see that they do scavenge these cells, but they have impaired acidification of these lysosomes, which causes actually that these antigens are loaded on MHC molecules and presented to the T cells to activate the immune system. And now they become these show me macrophages, so they present antigens to T cells. This clinical development has now undergone or has been investigated in a clinical trial investigating the safety and preclinical or clinical efficacy of this bexmarilimab in this MATINS trial. We have now treated 150 patients around in total, and you can see that there are a nice response rate as bexmarilimab monotherapy in cutaneous melanoma, cholangiocarcinoma, gastric cancer, hepatocellular carcinoma, and estrogen receptor-positive tumors. Here are the spider plots of the best 2 cohorts so far, where we actually see a very nice stabilization of their tumor growth on bexmarilimab treatment. So I want to just finish to thank my lab, who has really been working a lot on the clinical samples. So Miro was the one to identify the mode of action of bexmarilimab in the M2 macrophages. Jenna is now doing a lot of studies to investigate how bexmarilimab is activating the immune system in the tumor microenvironment by utilizing patient-derived tumor explants that we obtain from the hospital. And that's done also in the Cancer IO consortium together with Klefstrom Lab and Mustjoki Labs. And then I want to thank all the other people. Sina is working on mice, and now I have recruited 3 new PhD students who have started this year. And then I want to just thank my funding agencies and you for listening. Thank you very much for your attention.
Thanks. And then questions? Riitta? Toista se kysymys.
Rita asked me if there is any harm on treating patients with anti-Clever-1 and does it have any effect for infections. And so the first answer is that it has been very well tolerated. There are no safety issues whatsoever. So we feel that it's very safe. So there are no grade 3 or 4 adverse events occurring. And so for infections, we have investigated that bexmarilimab does not inhibit Staphylococcus aureus uptake. So the epitope where the antibody binds is not impairing that activity on Clever. So, and also you have shown in previous publications that the bacterial clearance is not affected by Clever inhibition.
Any other? Is there any in the net? Oh, the very silent people, or maybe they are very shy. Okay. Okay, maybe everything is so clear.
Yeah. Good
Okay,
job.
thanks.